All right, go ahead, Natalie.
All right. Well, welcome everyone. It's good to see a lot of familiar faces and names. We are very excited to be able to offer you today's webinar and training. It's focused on community health centers and helping organizations prepare for sustainability and coverage of their DPP. We are excited to have had the opportunity to work with both Atromitis and Evolve Health Strategies to help us with preparing some of the information that we're going to share later today. So many of you have probably had the opportunity to speak with or actually interview with both Peter and Lavandia, who are going to lead us through today's training. But many of you have had the opportunity to participate in both surveys and interviews. And the intent around those were to help Peter and Lavandia really understand the structure of your organization. So they learned a little bit more about your organizational staffing structure, what types of quality metrics you're currently collecting, your experience with payment structures, and many other things around revenue cycle and HRSA site visits. And they've taken those learnings to prepare today's conversation and today's webinar on really how to navigate some of the barriers of offering the National Diabetes Prevention Program in community health centers, as well as providing you with insights how you can ensure that your program is sustainable as we move forward into these final years of the grant. So I am going to go ahead and turn it over to Peter and Lavandia so that they can take you through today's training.
Great, thanks, Natalie. Good afternoon, everyone. I don't think we have anyone in the morning time, but if we do, good morning to you. We'll do introductions in a minute or two, but as Natalie said, the purpose of today's presentation is to think through the relationship between community health centers and the National Diabetes Prevention Program, with the very real understanding that there are a lot of caveats to being a community health center that pose challenges and barriers to implementing something like a federal program like the National DPP that other provider types don't necessarily experience. And so over the past couple of months, as we have talked to you, we have come to get a better understanding of where you are, what your challenges are, and we've put together a host of collateral that you will be receiving following this training that thinks through the finances, the operations, the ties to quality that Lavandia and I have put together. And so the purpose of today's training is to both provide an overview of those, as well as to sort of give you an idea of how to interact with the collateral once it's finalized for you all. So a couple of just quick disclaimers. This is supported by the cooperative agreement that that ADCES has with the Centers for Disease Control. It is paid for off of that funding stream. And this presentation is copyrighted to ADCES. So I will let Lavandia do a quick introduction of her first.
Good afternoon, everyone. My name is Lavandia Alexander. I am the founder and president of Evolve Health Strategies. As I met some of you, I did not get to meet all of you, as Peter had some interviews and I had others. I am also the Chief Quality Officer at Contegra Health, which is a FQHC based out of North Carolina. So I too understand a lot of your challenges with being an FQHC, how we are treated differently than our private counterparts in the community. So I look forward to speaking with you today, and we look forward to you receiving the collateral that we hope will help you with the implementation and sustainability of your DPPs.
Great, thanks, Lavandia. And I'm Peter Freeman. I'm a principal with Adromitis, which is a consulting firm based in Wilmington, North Carolina, but we have offices around the country. I am personally located in Chicago. I spent a number of years working at an FQHC in New York City called Ryan Health. I was the Senior Director of Population Health and Chronic Disease Management. And then after that, I spent a few years down in North Carolina where I had the benefit of meeting Lavandia, working at that state's primary care association, helping FQHCs work through the transition to Medicaid managed care, which they finally, quote unquote, successfully did July 1 of this year. So I also have a background in working within and supporting FQHCs across funding streams and thinking through how to integrate all of those programs together. So we're really excited to partner with ADCES on this work because we have felt your pain over the course of our career. A couple of quick housekeeping items. So we're going to keep all of our participants muted during the presentation. We ask that you use the chat box to pose your questions. We will do the questions at the end of the presentation. We'll wait till the end to answer them all. There will be polls throughout the presentation. I think 2 or 3 that we'll ask just to sort of see where you sit with how all of this fits together. And this presentation is being recorded, partly because unfortunately not everybody was able to make it today, but you also should have gotten the notification that the recording was started. One other disclaimer for all of you. So the material covered today, and this disclaimer also lives in the collateral that you will receive from us after the presentation, is really intended for informational purposes only. It is not intended to be considered clinical, operational, or programmatic guidance for health centers when they are thinking of implementing the national DPP or the national DPP lifestyle change program. All that we present are meant to be recommendations or ideas or concepts that should follow the appropriate leadership protocols of your community health center, your clinical leadership, your operational leadership. You know, even though Lavandia has clinical backgrounds and I have worked operationally in FQs in our roles working with our consulting firms, we are not intending to stand here and tell you exactly how to do the things. So we just wanted to reemphasize that this is for informational purposes only and to give you some ideas on how you and your teams may approach working the national DPP into workflows and infrastructures within your health center. This is our agenda for the afternoon. So we'll do just a quick background on sort of where these collateral came from, and then we'll do a couple of slides on sort of how Lavandia and I concepted the national DPP to fit into the CHC world. We'll talk about some of the care and services around diabetes and how those tie to the national DPP and what your financial benefits are for successfully implementing the national DPP. And it'll be above and beyond the reimbursement received from providing those services. This is thinking about tying it to all the rest that you do as a community health center. And because this is a training, we like to give you some tactical, practical things to do. So there is a little bit of what you can do following this presentation. And then we'll go into some questions if you have any, we'll follow up with a list of resources. So as we said before, please put all of your questions in the chat box. Lavandia and I will be monitoring them, and we will do our best to capture all of them and respond to them all at the end of the presentation. So first, a little bit of a background on the national DPP and CHCs. So as Natalie mentioned at the top of the presentation, we were engaged to help understand where the CHCs participating in the 1705 cooperative agreement were with their implementation of the national DPP and specifically the national DPP lifestyle change program. You know, I think we all know that if you look at one community health center, you've seen one community health center, and it is therefore also true that how one community health center is approaching implementing something like the national DPP is very different than how another may be. You still have your federal guidelines and regulations you have to follow, but your staffing models are different, your infrastructures are different, the number of sites you have, the services provided at each site are different, your quality infrastructure is different. And so our intent was to really try and help ADCES understand what were your challenges, what were your barriers, and then also think through what we knew about our experience working in health centers about how you get paid, what are your opportunities for incentives and reimbursements, and how it can all sort of come together. So just real high level, I think this is familiar to all of you as you have been part of this program. The goal of the National Diabetes Prevention Program is to make it easier for people with prediabetes to participate in affordable, high quality lifestyle change programs to reduce their risk of type 2 diabetes and improve their overall health. There is a shown reduction of risk in developing type 2 diabetes for those who participate and conclude their participation in the National DPP Lifestyle Change Program. And what we found with working with all of you and talking with all of you is that, you are unique in the challenges you face in implementing this program. And not only are you as CHCs unique, but each of you as a CHC are unique compared to the other 7 of you that are participating in this grant. So specifically what ADCES was looking for was they wanted to find a way to further support community health centers, recognizing that they are a unique provider type, and also recognizing that community health centers are focused in areas of traditionally underserved populations and underserved areas of care. They wanted to make sure that they were really providing a full suite of support to you all in implementing this program. So specifically, they wanted us to help think through how the National DPP connects to the other services that community health centers can and may be providing, as well as building a way for the program to be financially sustainable around diabetes, and that specifically includes the National DPP. After our conversations with you all, we sort of spent some time mulling over the data you provided us and the feedback you gave us. And we came up with 3 opportunities that we will walk through this presentation on where we think, or where we got the feedback from you all that CHCs were struggling with the National DPP. And the first was really trying to put it into context of a larger suite of diabetes care. Diabetes has been a huge area of focus for community health centers for a large number of years. I know HRSA and BIPIC have been mentioning diabetes for a long time for community health centers. And so thinking through how can the National DPP serve as an anchor or a primary component of a larger diabetes management program? What does that look like within how CHCs function and the type of services that they can offer to their patients? The second was to think about, and somewhat related, the National DPP is not a standalone answer to diabetes care, right? It is an attempt to reduce the risk of type 2 diabetes for patients through the lifestyle change program. But we also know that unfortunately, there are patients that go through that lifestyle change program who then still progress to a type 2 diabetes diagnosis. We also know that there are patients who successfully do not transition into a type 2 diabetes diagnosis, but they still need support in managing, addressing, or identifying other health conditions that may put them back on the path of increasing their risk for type 2 diabetes. So we wanted to think through and help you all think through, well, what does that actually mean? If the National DPP can't exist in a silo, what is everything else that's going to be around it? How does it feed into other services? How does it support other prevention services that you may have? And how do you think about all of the different risk factors that patients might have who are eligible to participate in the National DPP? And then last but not least, we can't talk about services at a community health center without talking about funding and finances, because it's important to all of us. So we really wanted to think through how can the National DPP be used as a way to, 1, address diabetes-related clinical quality measures, either through HRSA, Medicaid, Medicare, some of those low-hanging fruit. We all have payers that contract us to take care of patients with diabetes or at risk for diabetes. And then secondly, in addition to those incentive payments, how can it help us just increase reimbursable services? Incentive payments are great. They come at the end of the year. They sometimes come in a large check, and that always feels really great. But there is a way to think through the National DPP in a way that can incrementally help us increase reimbursable services throughout the year, either because we are providing better primary care to our patients or more coordinated care to our patients, or we are helping patients more appropriately access healthcare, which opens up slots for you to see more patients and bring in new patients to provide them services that they need. So we realized that there was a need to think through the financial viability of the program and the different ways that that can be accomplished. So the first thing we wanted to think through was the diabetes spectrum of care and where does the national DPP fit into it all. But first, we're going to start with a poll because that's always fun. So on your screen, you should have question 1 popping up. So what HRSA quality measures are related to diabetes care? And you pick the answer that is correct for you. There's only one answer. And we'll keep this poll question up for about 30 to 40 seconds. I'll close it in about 5 more seconds. All right. So the correct answer was D. It's both BMI screening and follow-up plan, as well as the hemoglobin. I'm sorry, it was D. I think I said that wrong. The correct answer was D, which includes both BMI screening and follow-up plan, as well as hemoglobin A1C poor control measures. Great. So when thinking about a larger diabetes infrastructure within health centers, as I mentioned earlier, we all know that community health centers have been asked to address diabetes prevention and treatment within their patient population for a very long time. There was a big concerted effort that came maybe 5 or 7 years ago, and then 2 years ago, HRSA implemented their diabetes action plan into their site visits because they really wanted health centers across the country to really focus on this population, because nationally our numbers aren't doing great, and within the community health center world our numbers were starting to go in the wrong direction. So just some stats to sort of highlight why diabetes care within the CHC population is important. About 15% of CHC patients have been diagnosed with diabetes. Of those patients, almost a third of them have an uncontrolled A1C. It is important to note that that is a combination of patients with a known A1C level that is higher than it should be, as well as patients with an unknown A1C level who have not come in for their A1C test. And then almost 3/4 of CHC adult patients had a BMI that was out of range and then also received a follow-up plan. And as Lavandia will talk about in a little bit, weight is one of the risk factors of diabetes, and it's associated with negative health outcomes for those at risk for diabetes. So thinking about those patients who have a risk factor that is not being addressed is important when we start trying to package this all together in all that CHCs do. So community health centers who applied for the ADCES 1705 opportunity were doing so because they were part of these groups that were seeing an increase in the number of patients with a diabetes diagnosis. And they also wanted to help support their patients who were at risk for type 2 diabetes in lowering their risk. And we know that because we looked at your applications to the 1705 grant. So we know why you're all participating. So this you will see in one of the collaterals that you will receive after the training. But what we wanted to do, we recognize that ADCES's 1705 grant opportunity for you all was specifically focused on understanding the National Diabetes Prevention Program and the associated lifestyle change program, the mechanics of how to apply to become one, to be recognized as one, the things you need to do for patients that are eligible for the program, understanding the eligibility, and the way you need to engage with them over the 1 to 2 years of the lifestyle change program in order to help reduce their risk. What we know is, one, the National DPP Lifestyle Change Program takes effort. It is not an easy thing to stand up. And so we also know that the patients that engage in the National DPP Lifestyle Change Program, as we talked about earlier, are not necessarily going to go through the program and then be perfectly healthy and be done. Some of them may be, and that is great, and we support those patients, and that is fantastic. But some of them will unfortunately progress to a type 2 diagnosis, and some will have other comorbid conditions that they either didn't know they have, they may be unaddressed, they may be uncontrolled. And so thinking through, well, if you stand this program up, what does that mean? You can't stand it up in a silo. And so we really thought about your public health, addressing of conditions, prevention, treatment, and maintenance. And National DPP, it is in the title, is a prevention program. And so that is for helping patients who have not yet progressed to type 2 diabetes move in that direction. But again, we need to recognize that for various reasons, they're not able to attend all of the classes. They have lifestyle factors outside of their control that are impacting their ability to control weight and the food that they eat or their physical exercise. There may be challenges in how you are getting reimbursed for some of the services you provide. There are a lot of reasons why patients may be unsuccessful in reducing their type 2 diabetes risk. And so we wanted to think about, well, what are the things that health centers can do or may be able to do on the treatment side if you do have someone who progresses to a type 2 diabetes diagnosis? And some of you may already be engaged with ADCES on this, but we are thinking about things like the diabetes self-management and education services for patients that have already had a diagnosis who are needing to learn how to manage that condition and all that comes with it. We're thinking about Medicare's chronic care management program, so how you engage patients on a regular basis who have a chronic disease or condition that requires regular follow-up, regular touch points, regular services that they need in order to keep their health status at a certain level. And then we also wanted to think about the larger scope of services that health centers provide in the primary care world. So health centers are in large part a wraparound full service primary care offering for their patients. And primary care is going to span the spectrum of diabetes care for all of their patients, but specifically for those that engage in the National DPP Lifestyle Change Program. So as Lavandia will talk about shortly, there are many other conditions that patients may need to think through and need help addressing in addition to just those factors that increase risk for type 2 diabetes. But we need to know what they are, patients need to be made aware of them, and we need to know that we have the services on hand to provide to those patients so that we can help provide a whole person approach of care around their diabetes risk. And then medical nutritional therapy is also something that can be done as a preventative treatment or maintenance measure. And we wanted to help think through who needs to be available for that service, who's required to bill for those services, and the types of services that can be offered to your patients that fall under MNT. So the collateral you'll get related to this talks through more about how to think through the National Diabetes Prevention Program within a larger diabetes care infrastructure within your health center, and how can you think through setting something like that up. And with that, I'm going to turn it over to Lavandia to take us into the more clinical stuff that I should not be talking about. And Lavandia, just let me know when you want me to switch slides.
So we're going to be talking about the care around diabetes. Many of the things that Peter alluded to, we will speak about in the next couple of sections. We also will be talking about the care around diabetes related to the framework that Peter just presented to you. But first, there's a poll. Next slide. With this one, what factors contribute to the progression of diabetes? Please check all that apply. And Peter, if you can share the results.
Did the last poll not show up at the end?
No.
Oh, great. So then I don't know if I can, but I will tell you what they said.
We'll give you a few more seconds here.
All
So it was all of them. So we have weight, social determinants of health, genetics, and comorbidities can all contribute to a patient developing diabetes. Next slide. So when we're looking at the spectrum of diabetes care and the framework, we also have to look at a whole person approach. So when we're looking at the activities of the National Diabetes Program Lifestyle Change Program, there are opportunities for you all as coaches and staff supporting the program to identify areas that can, one, be transferred to your primary care services, and also assist with managing people with diabetes or with pre-diabetes, offering services that could keep them from obtaining diabetes. So look at how we can use the things that you can do from a pre-diabetic perspective, looking at comorbid conditions and those who transition to diabetes to support primary care services. Next slide. So let's first talk about potential services with patients with prediabetes. These are the main focus patients that you guys are looking at in the program. When doing research, we found that most payers, based on research, please confirm with all of your billers, coders, and financial people and revenue cycle prior to implementing all of this. But these 5 services are typically covered for those with prediabetes as a diagnosis. So you have blood glucose testing. We want to make sure that we keep an eye on that. Blood pressure check. That way, if we do a blood pressure check, we can see if someone is developing hypertension. A cholesterol check as a lab also can see if someone has coronary artery disease or on their way there through the checking of their liver function test to see if there are things there that we can look at. Nutrition counseling. People with prediabetes have issues with obesity. And then there's behavioral counseling for those with obesity that they also qualify for, and this would be with a licensed behavioral health provider. Next slide. Peter also spoke to patients with comorbid conditions. So with diabetes, there tends to be issues with dental, hypertension, chronic kidney disease, vascular disease, just to name a few that we want to help manage for our patients. Also, as spoken to earlier, you don't have to have diabetes to have these comorbid conditions. You can have pre-diabetics that have these that can elevate or escalate their chances of developing diabetes. But even if they do not, that 48% that are successful who finish the program can still have these comorbid conditions that can put them at risk. So what can we do for these patients to alleviate these issues? Well, there's medical nutrition therapy, as you saw on the slide earlier, that can go across the spectrum of patients and across the framework, whether they have diabetes, comorbid conditions are in the program. Again, some of the things that you can do: blood pressure checks, cholesterol checks, and behavioral health counseling. But the behavioral health counseling at this time is not limited to obesity. I'm not sure if any of you know, but for chronic conditions, most of us have LCSWs or like professionals and providers that see our patients, that there can be integrated behavioral health visits that support the primary care provider for some of those cognitive behavioral changes that will help a patient do the things that they need to do that their primary care has asked of them, but maybe there are social determinants of health that they're having issues with that the behavioral health provider can assist with. Maybe there are change management issues with the patient. So we are all very familiar with the integrated health and behavioral health program. So these are some opportunities. Next slide. We've spoken about this throughout the presentation. Despite participation in the lifestyle program, there may be biological factors, those that have a history of diabetes in their families. Social determinants of health. We typically call these patients non-compliant, but we have to ask ourselves, why are they non-compliant? Can they not afford their medication? Do they not have transportation to get to their provider offices or their specialists, depending on what they need? Do they have the right money to get the right food at home? Are they having issues with other things like homelessness or housing or electricity that makes them not be focused on their disease processes? So we want to make sure that we also look at these things and maybe refer them to either social workers, LCSWs, or community health workers within our operations to assist with these things. Next slide. So unfortunately, for those who do progress to diabetes, there are more services that your primary care providers and staff can assist with. Once the patient has developed diabetes, we want to transition to hemoglobin A1C testing as the best indicator of how they are doing with their progression to get better with diabetes. We also want to keep an eye on their kidney function by looking at their microalbumin. We also want to look at their retinal eye exams. Many of us do not have those services within our organization, and we do refer those out. But having a watch over that with our patients is really important. Making sure we take those shoes off at every visit and looking at the patient's feet that can prevent ulcerations and other issues that may come up through a foot exam. And as I mentioned earlier, having dental services. Diabetes and adverse effects in dental have been correlated to show negative outcomes in our patients. And then there's the diabetes self-management education support that can be provided for these patients. And as we get into the next section, we can speak about how these services can promote additional visits within your organization, increase productivity that then increases financial outcomes. Next slide. So how do I staff to do some of these things? When we spoke to you, we saw that as a FQHC, and this is normal, that there may be limited specialty staffing within our organizations. Like I said earlier, we may not have an endocrinologist, we may not have an ophthalmologist. So what can the staff within our organization do to help integrate those primary care services once we may have an indicator that we notice within the lifestyle program? So when you have a cholesterol and a blood pressure check, you can have a nurse do that, a medical office assistant, or a provider visit and have those done. Oftentimes in my health center, what we do, we have something that we call a medical recall visit. So if you have a patient that you identified in the National DPP Lifestyle Change Program that had an elevated blood pressure through your survey process, or if you took labs and you saw that that was one of the reasons that they came to the program, that you can have a follow-up with your medical provider, because that may be an indicator that they are now developing other conditions that may affect their progress to having diabetes. Also, the A1C and microalbumin testing that can be done by a nurse or medical assistant through point of care right there within the office, or a medical provider may order that through labs. The diabetic eye and foot exam must be done by a provider. Well, let me say in most states, it needs to be done by a provider. There may be different licensure scopes of practices in the various states that you are in. Again, for any of this, with the staffing and resources, check with your state agencies for nurses, providers, MAs to ensure that they can perform these services. And behavioral health counseling, a lot of times they don't have to be an LCSW, but they may be other behavioral health providers that can also provide these services. Next slide. So if we expand care outside of the program to the primary care provider, what does this do? It identifies emergent health conditions, as I spoke to. If there's an elevated blood pressure, is this person developing hypertension? Also, it allows for earlier intervention so that if we do find a comorbid condition, then we can intervene early. And it also supports patients in managing their chronic conditions, such as hypertension, if they have diabetes and chronic kidney disease, especially with those three, because they're so interrelated in the progression of each of them. Next slide. So next, how can we control the finances of the National DPP program? But before we start, there is a poll. We gave you guys an easy one.
And while you're answering the poll, one thing I will add for the staffing considerations in the collateral, you'll see Lavandia and I really tried to think about not only who was required for specific services, but how you can also leverage whomever you may be bringing on to run your lifestyle change program. If they're an unlicensed individual, if they have a lower license than a full provider, whatever the situation may be, the different ways you may be able to bring that person into clinical workflows, care management workflows, help them understand the range of services that DPP participants may need or want, so that they can help be an additional source of coordination and management for that patient's care.
Thank you, Peter. Everyone got it right. Performance on quality measures can generate revenue for your health center. To add on what Peter was saying, it was also challenging to determine the scope of practices within the states for what they can do. So we want to make sure that you guys follow your state guidelines. Also, to add on what Peter said, in developing the collateral, I just lost my thought there. Let's see, let's go back a couple slides, Peter, if you don't mind. Go back to the services. So looking at the services and the things that you can do with pre-diabetes, comorbid condition, and diabetes, looking at the scope of practices there, but also as we move into the finances, check with your billing and your coders to make sure that these are paid services within your primary care fee schedules within your organization's payers. You can go back to the last section with finances. So quality care and financial gain. So those who are also participating in the program, we can help community health center patients improve in their outcomes, which helps them improve performance on your CQMs. So appropriate care services has improved performance on your CQMs that go into financial incentives. So some of you, as myself, may be a little upset with what HRSA did this year. Typically, HRSA offered direct rewards for quality improvement through our UDS measures. This year, that program has changed to community health quality recognition. So the quality program as we knew it with HRSA is no longer in place. However, improving the outcomes of our patients through diabetes, hypertension, looking at other outcomes for the patients, we are now going to get pay for performance rewards, quality rewards, and grants, but you need to look for the announcements for those, as they will not be associated with UDS specifically. There are resources on the HRSA website that get more into detail. There are webinars that were recorded to show how this has changed, but I do not want you to think that the rewards have totally disappeared. They're just going to present themselves in a different way. Next slide. So looking at payer incentives, like I was saying with HRSA, those things have changed, but also other payers provide support and opportunities for CHCs to get payment for meeting CQMs, and not just CQMs, but improving the outcomes of their patients. Next slide. So let's take these payers one by one. As an FQ, most of our patients are Medicaid or Medicare alongside the uninsured. We have a small commercial patient base. In most of the states that we looked at and around the nation, Medicaid is managed by payers, commercial payers with MCOs, and they typically offer incentive payments or shared savings for organizations that do well on their CQMs. We looked at many of your Medicaid programs and looked at the MCOs and the quality measures that they were following. We looked at the quality measures that you all are following, and many of them align. For Medicare, we see that right now is one of the fastest growing patient populations within community health centers. So many of you are part of an ACO. We do know with the ACO, how well you do on your CQMs determine how much shared savings you get. So typically most of us are in track B with our ACOs that may receive 40% shared savings. If we get a good quality score, those who are at risk, there's even a higher incentive. So this where it comes out that we want to improve patient outcomes overall. So by having those patients with prediabetes or other comorbidities that you may identify in the National DPP Lifestyle Program through your screening or through your working with the patients, by getting them connected back to primary care, you'll help improve those outcomes of the patients that decrease utilization and also offer an opportunity for shared savings for your organization. This is especially true in Medicare Advantage plans that you all may have. They really have a lot of incentive payments for different CQMs to include A1C, microalbumin, BMI. You can have enhanced reimbursement rates for participating in some of their quality programs. And there are also opportunities for shared savings that you may be eligible for. Next slide. As I stated earlier, it's not common for commercial payers or private insurance, as we typically call it, to offer incentive payments, but there are some that do. What you will see is a lot of clinically integrated networks are partnering with commercial payers to offer shared savings programs, and they're looking at diabetes. Diabetes has its own section of ECQMs that they're looking at. They're looking at patients on statins with diabetes. They're looking at A1C. They're looking at microalbumin. So they're looking to make sure that diabetes is controlled across the spectrum, not just with HRSA, but a lot of commercial and Medicare Advantage plans are looking at that. So make sure you pay attention to your commercial payer contracts to see if there are opportunities. I know that, just to give you an anecdotal example of how my organization improved our quality through our HRSA diabetes program that we had to do, as well as looking at the contracts that we had. I took my department in quality where we were not receiving any incentives, and we slowly started looking at contracts where they were low-hanging fruit, and diabetes ended up being some of those low-hanging fruits because they aligned with the HRSA measures that we have to do with UDS in many occasions. Next slide. Also, remember that clinical services equal billable visits. Your finance teams and operational teams would be very happy to see if your coaches and staff that are working in the lifestyle change program, as Peter stated, can identify and be educated on how you guys integrate with primary care services to increase that productivity and the number of billable visits that your providers can have, not only in the primary care services, but as well as mental health if you have integrated behavioral health in those counseling sessions for those with obesity and those with diabetes and other chronic diseases. Next slide. So you may be asking, what can I do next? So you want to partner with your patients and your care teams. You want to identify those primary care services that can enhance patient outcomes for those participating in the program. Education is key. You also want to learn about your value-based opportunities, no matter what payer is with, to see where you can have revenue streams related to diabetes. And your QI plan. Everybody's required to have a QI plan by HRSA. It is part of your 19 requirements. Make sure you incorporate diabetes into that QI plan. When we spoke to many of you during your survey, you're already doing this. Diabetes is a major factor in the outcomes that you guys are monitoring when speaking to a lot of you, so you're already doing the work. And again, educate staff on opportunities for engagement and improvement. Next slide. Oh, go ahead, Peter.
I was just going to add that there is a second layer of what you can do next in the resources that we are finalizing with ADCES. In addition to these sort of high level ideas, we also, for each of the individual pieces of collateral, the one on the framework, the one on the services, and the one on the finances, we provided additional steps that you can consider within your health center on further incorporating those that are operating your national DBP lifestyle change program. So thinking about huddles, thinking about clinical consultations, thinking about how those staff can do outreaches when they're doing reminder calls, scrubbing patient charts, understanding your CQMs, how you can further support your billing and coding staff. So when you receive those resources, there will be additional next steps more closely tied to those specific pieces of collateral that we have developed in partnership with ADCES.
Another anecdotal story I would like to tell you, we mentioned chronic care management for those who have Medicare earlier, and they only need one chronic condition now that started in 2021, just to make sure that we relay that back to the financial services. So identifying that if you have a CCM program within your health centers, and if you do not, to think about implementing that. Health centers receive reimbursement for, speaking with the Medicare patients, each month on managing their chronic diseases. Next slide. So we are at the end of our presentation. I have been monitoring the chat. There doesn't seem to be any questions in there thus far, but we want to open it up for anybody to come off mute and ask any clarifying questions or any expansion on the information that was received here. As a reminder, this was a macro level overview of the collateral that you will receive that goes more into depth of what we spoke about today. So what questions do you have? Again, everyone is muted, so if you have a question, you'll need to come off mute as well.
If you are finding yourself unable to come off mute, let us know in the chat box and we can help control it from our end.
It's not a question, it's just, my name is Rosa Stella Lara and I am in El Paso, Texas. And it's not a question, it's just a comment that everything else, all this information is new to me. And I am a person with diabetes, and I'm just amazed. I'm just amazed of all the information that is out there that you guys are providing for me to provide to my patients now.
Thank you.
Thank you. Thank you.
You're welcome. Well, we'll turn it back over to ADCES to close us out. Natalie, if you would like to.
We have one
Yeah,
more
let's-
question,
Oh, sorry.
actually.
Yeah, looks like there's a question in the chat box.
Oh.
Which came from Myra. She said, we provide chronic care coordination. Is it considered a CCM?
So again, make sure you do your own research, check with your financial department before following the information I'm about to give you today. So chronic care management from CMS for Medicare patients is any 20 minutes that you serve with a Medicare patient that has had a qualifying visit, meaning whether they had an annual wellness visit, they had a visit with their PCP, and they consent to being in a chronic care management program that allows you to call them once a month or contact them for once a month. You are able to bill for any research, any referral management, you talking to the patient. You can talk to them more than 20 minutes, but once you get to 20 minutes, you are able to bill for a CCM encounter. So I'm not sure what you do with your chronic care coordination program, but if you have Medicare patients who give consent to the program and are providing 20 minutes or more to their care and managing their chronic condition, you can bill for CCM. Thank you for that question.
Great, thank you, Lavandia. Any last minute questions before we wrap up for today? Don't be shy either.
And if anything comes up later, Natalie, I'm not sure if you guys want to field the questions back to us or provide Peter and I's information. We'd be more than happy to answer any questions after people have had an opportunity to review the collateral or think about things after the fact.
Yep, so that's a great point. So just to kind of wrap up for today, as both Lavandia and Peter mentioned, we have been working over the past several months to create a collateral of resources that were touched on today, really. And within those resources, we expand even further on some of these topics. They've given really great recommendations and suggestions for you all to consider implementing within your health center. So again, this is just really high level, scratching the surface. We want you to take time to review and digest what's in these resources that we will be sending out after today's call. So if you do have additional questions, you can feel free to direct those to either Patrick or myself, as always. But we will include both Peter and Lavandia's contact information within that email communication. So if you do want to ask your questions directly to them, you're more than welcome to do that. The last thing that I do want to just mention is that, again, this was really intended specifically for you all as program coordinators and the ones kind of leading the charge when it comes to DPP at your organizations. We look forward to continuing our relationship and partnership with Actromitis and Evolve Health Strategies to really see how we can continue to support you in your community health center and how we can continue to help you as we kind of move into these later years of the grant and ensuring that you all feel like you've built the infrastructure needed at your organization to feel as though you are sustainable and can continue to offer these great services at your organizations. So I'm going to go ahead and if there's no other questions, we want to just thank you for your time today. And thank you both, Peter and Lavandi, and we hope everybody has a wonderful rest of the day.
Thank you.
Bye. Have a great day.